All right, well, welcome back, everyone. Hope you are enjoying this day of discussion and information sharing. My name is Dr. Liz Lageson, and I'm the director of the UCLA Tarjan Center. And it's my sincere pleasure to introduce my friend and colleague and our next speaker, Dr. Rajuda Wilson, who will be presenting on moving the needle in understanding motor challenges and neurodevelopmental disorders. So by way of background, Dr. Wilson is a behavioral child neurologist specializing in autism spectrum disorders and related neurodevelopmental disorders. In addition to serving as our director of research for the UCLA Tarjan Center, Dr. Wilson is an assistant professor in pediatric neurology and psychiatry at the UCLA David Geffen School of Medicine and the UCLA Center for Autism Research and Treatment. Dr. Wilson's NIH-funded research is focused on developing quantitative methods of motor phenotyping to improve characterization of motor development, also better understanding how specific motor impairments can impact cognition and language, and in developing more targeted interventions for children with neurodevelopmental disorders. Dr. Wilson's work also extends to measuring the physical and behavioral benefits of organized physical activity for children with neurodevelopmental disorders. She works with community-based organizations like sports programs to improve coaching education on neurodevelopmental disabilities and helps to measure motor and behavior outcomes of these programs. Clinically, Dr. Wilson sees patients in the UCLA Child and Adult Neurodevelopmental Clinic and in the Care and Research and Neurogenetics Clinic. Dr. Wilson has received numerous awards and accolades, including being selected as a Los Angeles Times Super Doctor, Southern California's Rising Stars, and as a Los Angeles Magazine LA Top Doctor. So we feel truly honored to have her on our faculty and as our Director of Research at the Tarjan Center. Dr. Wilson's lecture will be followed by some thoughts and reflections from one of our community discussants, Dr. Danielle Barber, and then a brief Q&A session with all of you. So remember that you can add any questions you have for Dr. Wilson or for our next presenter in the Q&A, which can be found on the Zoom toolbar. In the meantime, please join me in welcoming Dr. Rajuda Wilson.
Thank you very much, Dr. Lageson, for that very kind introduction. I'm very grateful to be here today, very impressed at the size of our audience and the phenomenal questions I've heard thus far today. So thank you for sticking around today and being here to listen to my talk as well. So as Dr. Lageson mentioned, I'm a clinician and a researcher. But really what I'm going to speak to you about today came from my clinical experiences as a trainee, as a fellow training in neurodevelopmental disabilities, and seeing these prevalence of motor challenges in the patients that I saw, and really the lack of our understanding of why they occur and maybe how to best screen for them and support them. And so the reason why I built the research around this is really to better understand these areas and ultimately improve the clinical care that we can provide individuals with neurodevelopmental disorders. I'll just quickly note that I will be using both identity and person-first language today. I'll be using terms such as autism and autism spectrum disorder, terms such as intellectual disability and minimally verbal or non-speaking. And really my goal is to be respectful to all and their preferences regarding language related to neurodiversity. Quickly, these are my disclosures, namely just noting the funding and the fact that I'm on the Best Practices Committee for Acing Autism, a nonprofit organization, but I do not receive any funding from them. So today I'm going to first start with speaking to you about broadly a background on motor challenges and the importance of motor function in neurodevelopmental disorders, autism, and genetic neurodevelopmental syndromes. Then I'm going to give you two examples outlining the research, really with the goal to understand how that could potentially change clinical practice. And first, that's measuring motor function as a biomarker, which means sort of a marker of predicting a diagnosis of a developmental delay, or monitoring for those who might be at additional concern for developmental delays. Then I'm going to talk about comprehensive motor measurement in individuals with genetic syndromes and neurodevelopmental disabilities. And then we'll finish out the talk by discussing organized physical activity programs, or OPA, as an intervention for motor challenges and hopefully support for other developmental domains in individuals with neurodevelopmental disorders. So first, let's talk about why this focus on motor function, or the importance of motor function. Well, motor development is really the earliest benchmark of developmental progress and is crucial in driving multiple cognitive processes. So what does this mean? It means that when infants and toddlers learn to sit, crawl, and walk, those are very important windows for clinicians and caregivers to monitor typical and atypical development. And it opens up the toddler's ability to engage with their environment, engage with caregivers, manipulate objects, and develop sort of spatial perception. Motor challenges are highly prevalent in neurodevelopmental conditions, including ADHD, autism, intellectual disability, and some neuropsychiatric conditions as well, such as Tourette syndrome and schizophrenia. And they're often shown to be in our literature one of the first signs of atypical development, or one of the first signs that may present in these individuals who later receive these diagnoses. Motor development can be observed and measured over time. So very important as a clinician or as a researcher when we're trying to develop tools for caregivers or practitioners to be able to accurately identify these early concerns. And it can serve as a target for intervention. And my hope and goal with this research is not only to improve motor development, but even broader developmental delays like language and social communication that motor challenges can affect. So first, to highlight sort of this prevalence, here at the top right, you see our Diagnostic and Statistical Manual of Mental Disorders, our DSM-5. And these are some of the listed conditions and verbatim what they say. So an autism spectrum disorder, for example, motor impairments are currently listed as an associated deficit, things such as odd gait, clumsiness, or other abnormal motor signs. This is exactly what it says, so certainly something that we should be aware of, but still a bit broad or difficult to fully interpret, maybe as all clinicians, as to what you may be looking for. Here you can see an attention deficit hyperactivity disorder, or ADHD. Delays in motor often occur, and there's a wide range of literature actually on early fine motor and gross motor signs in infants and toddlers who later go on to have a diagnosis of ADHD. In intellectual disability, it's noted that delayed motor, language, and social milestones may be identifiable in the first 2 years of life. So going to that, and I also want to just highlight here, when we think about cerebral palsy, for example, largely thought of as a motor disorder or condition or diagnosis, that there's a large intersectionality in those kids who have both motor difficulties, secondary to injuries or genetic syndromes, but also a large intersection with neurodevelopmental diagnoses, such as intellectual disability or autism or other broader social communication difficulties. But Dr. Barber, our discussant, will be mentioning a little bit more about that today, as will Dr. Fowler in detail. So I won't be touching on that as much, but will a little bit throughout my talk. So now I want to highlight this sort of paper as a case example again on autism, primarily because of some of the aspects that this study showed. This was a cohort study of about 200,000 individuals with autism in Australia, a retrospective study. And they found that about 35% of individuals met criteria for motor impairments. This rate was almost as common as intellectual disability. The prevalence of motor difficulties increased with age. So important to know this is not just in early childhood, but really increasing as an individual gets older. Yet diagnosing clinicians reported motor difficulties only in about 1.3% of cases. So that's why I want to highlight this study, is that there's a large prevalence, but a discrepancy in how often we're recognizing these challenges. And there have, of course, been studies of autism showing that 50 to 80% of autistic individuals have motor challenges. And these challenges go across many motor domains: fine motor difficulties, gross motor, balance, and coordination. So staying sort of in this framework of autism and broader neurodevelopmental disorders, I'm now going to touch on that first example, which is measuring motor function as a biomarker to predict developmental concerns. So certainly many of us likely know that there are some major delays in autism early identification. Recent CDC estimates that 1 in 36 children have an autism diagnosis, but the average age of diagnosis of autism really over the last 20 years or so has remained at 4 years, despite the fact that a majority of caregivers report symptoms prior to 3, and research shows that symptoms may appear even in the first year of life. And so how can we address these issues? Well, first, we can increase our training efforts in our clinical workforce. You'll see here on the left-hand side, 2 of our trainees, Dr. Lauren Waldron and Maya Ayub. Maya Ayub is a Tarjan Center trainee as well, who are training in neurodevelopmental disorders. So something that we're actively working on here at UCLA to train more individuals to recognize these early signs and see these individuals who have concerns, but is also to identify markers of risks or challenges that can be more objectively, or I should say precisely measured and reliably measured so that we can use it as a tool for clinicians to be able to inform a family that there are concerns. So staying in that same sort of diagnosis or that group that we were talking about with autism, I'm now going to use the example of infants with familiar risk or elevated likelihood for autism and broader neurodevelopmental concerns. Well, decades of research has shown us that having an older sibling with autism raises the likelihood of that infant having an autism diagnosis by about 20%, and other delays such as language delays, cognitive delays, ADHD, as high as 30 to 40%. And motor challenges are one of the first signs that have been shown or posited as a sign of atypical development. And you'll see that here on this picture, this sort of at 6 to 12 months of age, the sensory motor difficulties, and by 12 to 24 months, or really 2 years of age, the more visible sort of autism symptoms that clinicians recognize. And I'm not going to focus on the fact that all of this rigorous research that's been done in this population of infants in imaging, brain imaging, and eye tracking. But what I will note is, despite this beautiful work that's laid a groundwork for us, we still lack a robust clinical predictor of autism in the first year of life. Hence the reason to focus potentially on these motor abnormalities. I'll note, though, that so far, sort of current motor assessments that we've used in this population have yielded somewhat inconsistent results regarding what are the motor difficulties. Are they just milestone delays? Are they lack of movement or less movement? And whether or not they're actually more specifically associated to certain diagnostic outcomes, autism versus language delays, for example. So one of our research studies here in my lab is focused on developing what we call more quantitative measures of motor function in this population and examining if they might be associated with certain more atypical developmental outcomes or concerns. How do we do that? We use something here called a wearable sensor or gyroscope. One can think of it like a Fitbit, but having a couple more parameters it can measure, both acceleration and angular velocity, how you rotate or how you move. And you'll see an infant here in the middle picture and here at the end wearing these on their wrists and their ankles. And this allows us to look at really detailed type of movement early in life, movement duration, number of movements, variability of movements. And going back to that population we discussed, we enroll infants who are at high familial risk or likelihood for autism, and those who are at low familial risk, really defined by having no family history of autism or neurodevelopmental disorders. And we do very frequent longitudinal measurements in the first year of life and behavioral measurements. And then what we do is more outcome measurements at 2 years and 3 years of age, when autism is more typically diagnosed. And we can see what some of those outcomes may be. So this gives us an opportunity to develop more quantitative, hopefully objective, because it's not taking a clinician, requiring a clinician or a caregiver to rate the motor ability, but instead using this tool. And I say scalable markers because our study happens in the home environment of these families. So for those of you who may have participated in research, or probably for many of you who've been to the pediatrician, an infant or a child only does so much in that setting or that time that might be unfamiliar, but in their home environment, they do a lot more and are exposed to a lot more. So it gives us an opportunity to see their full movement repertoire of behaviors in a more natural environment. And it also allows us to see how these motor differences may change over time. And from a research perspective, when you're trying to develop predictors of concern or monitoring, those are very important aspects. So now I'm going to get into the science sort of quickly because I want to give you more a visual idea of what we're looking at, so it's not so abstract. What you'll see here on the right is one of our graphs of the data that we get from the wearable sensor. So on what we call the y-axis is our acceleration and angular velocity, two of our movement metrics, and on the x-axis is time. So really what you're just seeing is an infant moving throughout a period of time. And we have an algorithm to get rid of the noise and detect infant movements versus all the other movements that can occur, like sitting in a stroller or being bounced by a caregiver. But from this data, as scientists who see these patients or think about these neurodevelopmental concerns, we seek to create measures from this movement data that we think might have a particular link to certain atypical outcomes like autism or language delays. And so what do I mean by that? Well, let me give you an example. What you saw on the previous slide was this paper we had published on creating a measure of movement that measures complexity or variability of movement. Complexity of movement or variability of movement is defined by having the ability to develop a very rich repertoire of motor behaviors to achieve motor tasks. So it's well known that in order to achieve or gain a certain motor ability, reaching, walking, coordination, you have to have lots of different variable approaches to that, both errors and non-errors, to be able to learn that appropriately. And when really, as again, a clinician and a scientist, going back to clinical literature and research literature, what we've seen is that really optimal or good complexity or variability of motion has been shown, evidence has shown it's been related to healthy motor development. And when I write speculated, it's because I don't think there's quite enough evidence to say for sure or concretely, but enough that we've seen that this emergence of infant movements, variability of movements in utero, when the baby is yet to be born, emerges at the same time that very important brain connections form, like synaptogenesis or synapses, these impulses that our brain makes to learn. Conversely, sort of lower or poor non-optimal motion complexity has been shown in infants who have cerebral palsy or motor difficulties, has been shown with more repetitive movements, and again has been speculated that if you have poor complexity or variability in early life, it can affect certain areas of your brain that actually are important for your motor development. And because of that, it can potentially lead to more motor delays. So we hypothesized with scientists that perhaps having very poor variability of movement or complexity could underlie some of the motor impairments or challenges I've spoken today about in autism, the repetitive movements, which are a core diagnostic feature. And as a neurologist, what's also important for me to know is perhaps neurobiologically or neurologically, that maybe it represents some of the atypical formations in brain synaptogenesis that have been described in some studies of autism as well. So again, it's really just linking about causes of why for us to understand this. And so just qualitatively, again, to get an idea of what that means, we see one of our videos of one of our infants moving around, very cute infants, and you can see that this infant is moving up their hands, bringing them together, moving their legs back and forth, using sort of different movements. And we want to know, is there a very rich temporal quality of this, or is this pretty constrained? That's the goal. So let me show you now, kind of quickly to move through this example, what does that mean when we apply it in a research context? So as we look at our study in about 25 of our infants, I mentioned that we look at outcomes at 3 years of age. And so what you can see on this graph to orient you is on the y-axis we call here, is this measure of complex infant movements. On the x-axis are each of the time points that I showed you, 3, 6, 9, and 12 months of age that we measure them. In blue are our infants who at 3 years of age, with one of our autism measures, showed little to no concern for autism. And in purple are those infants who showed a moderate to severe concern for autism. And what you can see here is that the purple line shows lower complex movements compared to the blue line across these time points. And from a research perspective, that's significant at 12 months of age. So some promise to us that when we approach this, both scientifically and clinically, that perhaps having this poor quality or repertoire of movements could lead to underlie some symptoms of autism that we see at 3 years of age. So again, going back to why this is important. Well, it's important because it allows us to maybe not only predict, not necessarily only the goal, but really monitor those infants who might be at greater risk or likelihood for having developmental delays. And if we know that early in life, we can intervene earlier with motor therapies or other therapies with the goal to really improve language outcomes or cognitive outcomes or communication abilities later in life. I just want to quickly highlight a sort of community research. This is the Baby Siblings Research Consortium, which I'm a part of as well, but is a group of researchers who study these infant populations who have risk factors to developing neurodevelopmental disorders. And I saw some really lovely questions earlier, and I've had previous questions from members in the audience that asked, what can pediatricians do to inform parents about early signs and symptoms, and what are resources for that? So if you click on either of these links, there are some beautiful publications and videos made by very well-known researchers who've been working in this population for a long time to inform clinicians of what are signs and symptoms that can be monitored in early life or might emerge in the first year to 18 months of life rather than closer to 2 to 4 years of age. I'm now going to move on to that second example, and just a little quicker to kind of give you an aspect or understanding of this area of motor measurement in what we call genetic neurodevelopmental syndromes. So again, to define that, these are individuals who have a neurodevelopmental condition autism, intellectual disability, global developmental delays, but also have what we call a known genetic syndrome associated with that. And in the last decade or so, we've had really an advance in genetic diagnoses of neurodevelopmental disorders, knowing that about 20 to 40% of neurodevelopmental disorders have an associated genetic condition. And that's important for several reasons: diagnosis, treatment, therapy, and medical monitoring. So the examples I'm going to talk about here are first, duplication 15q syndrome, and second, ASX cell disorders. And what I want to highlight with this slide is that both of these pictures were taken at family conferences. So these conferences were put on by parent advisory groups and scientific alliances associated with these organizations. And these parent advisory groups, largely made up of parents who have children or caregivers who have children with these genetic conditions, have really been an incredible force of nature to come together and drive what they know is needed for their children and priorities of research. And they've done a phenomenal job of bringing together clinicians and researchers and providing them a foundation for recruitment and for speaking to one another in cross-engagement to improve clinical practices in these populations. So I want to highlight that as a part of these organizations, and maybe those of you who are here in the audience who might be a part of them. So why are we focused on these genetic conditions? Well, with these advances in knowing these genetic conditions, we've really sort of lagged behind treatments, right? And what we know is that, and I kind of highlight in a couple of these studies, is that there are higher rates and earlier presentations of motor challenges in individuals with genetic neurodevelopmental syndromes, and that these motor challenges are actually quite uniquely associated with their language and communication. Something that was highlighted here in this paper and subsequent papers of ours is that these motor difficulties might really underlie certain social communication areas and drive certain autism symptoms that may be different in those without a genetic syndrome and a neurodevelopmental disorder. But what do we know about many of our assessments in these individuals who often have intellectual disability, maybe minimally verbal or non-speaking, or have other behavioral diagnoses, is that really there is a lack of assessments that can be used to assess these individuals with these large range of abilities. And these assessments, motor assessments and others, even cognitive assessments, often have what we call a floor effect. What that means is that these children really score at the bottom, yielding very little variability or sort of meaningful information for us to take away in what to do and what to treat and how function might change with intervention. All very important things to be able to best support these individuals. So we really want to move beyond just capturing sort of a floor effect or just motor milestones. And as I noted before, more precisely measure these qualitative differences we see in motor function to understand what is happening, why it's happening, and what type of therapies we need to provide. So let me give you an example of that. These are two examples of children doing the movement assessment battery for children. It's a measure, a standardized motor measure used in children. It has different age bins and measures different categories of motor function. And it's a phenomenal measure. It's one of the reasons why we thought we would use it. But I'll give you an example of one of our kiddos doing it. And as you can see, he's walking across the line, attempting to here. And he kind of makes it across. And if you're not, I'm in the outside of the room, you wouldn't know if it's because he doesn't understand quite what to do. But really what we found is he didn't quite have the strength or the tone to generate his ability to kind of walk across it or walk across on his tiptoes like he was supposed to, one foot in front of the other and across the line. 3 different tasks he had to do. And then we see this other child right here. You can see that she makes it across the line fully. She does a great job. But what you'll notice, or I'll notice at least as a child neurologist, are very key features. The way she tiptoes in, she has inverted feet. She holds sort of one arm still. And when you examine her, when I see her, those qualitative differences is that she's more spastic or more stiff. But both of these kids scored the same on this assessment at the floor, 0 percentile, because they couldn't do the tasks as many as they were supposed to. They couldn't understand all the different levels of tasks they needed to do. And so again, we aren't really capturing that qualitative difference that we see. So now to move to this example, those 2 children had a condition called duplication 15q syndrome. And this duplication is one of the most frequently reported what we call copy number variants associated with autism. So a copy number variant is a difference in a genetic sort of what we call a duplication or a deletion within your genetic material that can lead to a genetic diagnosis associated with some things that you see here, like motor delays, autism, and epilepsy. And what I want to highlight in terms of with this slide is that our use of a quantitative measure and what we were able to do with it. So what we did here is we used a quantitative gait mat. It's a pressure sensor mat. And here with the pressure sensor mat, we're able, when the child walks across the mat, to pick up really important aspects of gait function, like pace, postural control, and variability. And rather than scoring at the floor, what we were able to do is we were able to evaluate a range of individuals with Duke 15Q with a large range of intellectual disability and ability. And we were able to find meaningful differences in this group compared to those with non-syndromic autism, autism without a genetic syndrome, and those with typical development. And what I show you here is just one of those variables called velocity, where you see in purple Duke 15Q, in blue typical development, and in green non-syndromic autism. And these stars indicate how significantly different they are. And what you can see is Duke 15Q is significantly lower than typical development and those with autism without a genetic syndrome. And even those with autism without a genetic syndrome are lower significantly than typical development. And what I note is that the ultimate goal of this work was to develop quantitative motor parameters that could serve as translational clinical endpoints for future treatment trials in this syndrome. And what I don't focus on here, but can happily convey, is now we do have, after a natural history study, all of this work, a clinical trial medication in duplication 15Q to measure whether or not it benefits cognition and motor function and other areas. So where we can go in better measuring these individuals to set up these therapeutic trials. With the time I have left, actually, I'm going to move on to organized physical activities. I'll happily share these slides talking about examining neurodevelopmental motor phenotypes in ASXL conditions. But what I'll highlight here, these conditions known as chromatin modifying disorders present with a range of motor challenges. And what we did in a pilot study presented by Dr. Maya Ayub is we used a multimodal assessment to measure these individuals to figure out what it does well in measuring and what doesn't. And ultimately, what we found out was that motor difficulties can negatively impact many aspects of these child's and these individuals' life beyond what we think about with therapeutics that we employ with occupational and physical therapy. So parents reported they negatively impact school activities, self-esteem, and social interactions. So it just shows the importance of some of these parental measures that really allows us to get to areas that need to be supported that we often overlook when we're thinking in the clinic about therapies that we're trying to employ. So now I'm going to move on over to our last area, which is organized physical activity as an intervention for motor challenges in neurodevelopmental disorders. Well, we know, I've already spoken at length about these motor challenges that we see in individuals with NDDs, and we know that they have significant impacts on physical health and well-being. These motor challenges often lead to more sedentary behavior, which leads to reduced peer interaction, more screen time, reduced or physical activity, compounding many things we see in these individuals like obesity, diabetes, cardiovascular conditions, and psychiatric conditions like anxiety and depression, ultimately leading to poor physical and mental health outcomes. Now, there have been many, many studies of physical activity for typically developing populations, showing that it's good for the brain, there's long-term health and mental health benefits, cognitive benefits, and several benefits in building social relationships. And what I highlight here is even benefits in brain function or networks in areas that might support things like executive function in children. From much fewer studies, we also know that there's benefits of organized physical activity for children with autism and neurodevelopmental disorders like ADHD in improving both motor function and non-motor symptoms. And I highlight two studies here to look at. On this side, what I just want the information for the audience to have is I chose 3 different studies out of the many who had different type of study designs and then ultimately looked at different outcomes. The first study that you see here is a very intensive 48-week program, which looked at basic coordination and strength exercises. And what they found was improved cholesterol levels, quality of life, and even repetitive and stereotype behaviors in autistic children. The second was a remote intervention, something that's much more common now. And there they saw those adults with Down syndrome who engaged 2 times per week saw a significant improvement in memory and in attention and reaction time, which was non-significant but improved. And the last one showing a 10-week sort of swimming. So again, I also wanted to highlight the different types of activities that can happen here. It doesn't all have to be rigorous, right? It can be readily accessible activities. So given that in this sort of area of motor, I was very fortunate to meet with Dr. Emily Coker when she was a medical student and she had asked to rotate in my clinic. She's founder of the Expressive Movement Initiative program, which is an expressive sort of dance or movement program with the mission to provide an expressive outlet for children with disabilities, foster mentorship and a sense of community among students and volunteers, and eliminate the stigma and reduce challenges associated with disability on the UCLA campus and beyond. She actually founded this in Oklahoma, and then we, in 2019, founded this organization here at UCLA. I'll highlight that it's fully student-run organization. All of the students now receive training in neurodevelopmental disorders, disparities in care, benefits of organized physical activity, and adapting movement skills. And it's a strength-based design. So really focusing on these children, these individuals' strengths, not necessarily challenges and what they're able to do. And so this highlights sort of thinking about interventions on motor function and maybe even the positive interventions that we have. So we chose then to apply for funding to the Autism Intervention Research Network on Physical Health to study this dance program as what we call a randomized waitlist controlled trial. And we do that here. You can see the study design, and I'll wrap up here soon. Sorry, getting the messages about time, but just want to highlight these last couple of slides. We do this by having those engage in both an active and control group, you'll see here. And to the right, you'll just see sort of the outline of what our classes look like. And what I want to highlight are just some of our pilot results, really just showing the broad effects, even in a pilot study, what we can have in motor skills. After 10-week in participation, we saw that individuals in the active group, here what you'll see in this first graph, showed a significant improvement in motor skills in a dynamic environment, and non-significant, but a trend and improvement in social communication skills measured on the social responsiveness scale here in the bottom. So just these broad effects. So I'm going to wrap up now quickly with just some clinical tips and referrals. I hope I highlighted that routine screening for motor challenges is extremely important, and to highlight that to your clinician if they haven't done that, just taking a developmental history can help with that, or using commonly used scales like the Developmental Coordination Disorder Questionnaire. Referral to programs adapted for individuals with neurodevelopmental disorders is important. I often recommend activities for families that reduce sedentary behaviors, even a 10-minute walk daily. Daily activities or tools in the home that I'll let our discussant talk about and Q&A talk about for motor skills. And then as a clinician, what I help families do is create sort of a medical profile for the child. This could be information on seizures, behavioral difficulties, language level, because we want to support the coaches in knowing how to best support the child. So with that, I want to thank you. I apologize for rushing a little bit there at the end, but wanted to get those important points in. And I want to thank you all for your time, all the families that participate in our research, all of the members who've contributed to this research, our funders at the Tarjan Center for this support, and of course, in advance, our discussant. Thank you so much.
Well, thank you so much to Dr. Rajuda Wilson for that interesting and informative talk. We're going to be hearing more from Dr. Wilson in our Q&A in about 10 minutes. As a reminder, as part of this forum, we have invited speakers from the community to provide their perspectives on the topics that we're covering. And our next community discussant is Dr. Danielle Barber. We are very excited to have Dr. Barber here, not only because she is a brilliant child neurologist and neuroscientist whose clinical work and research focus on early life brain injury, but she is also the mom of 3 children, one of whom was born with a neurological condition known as HIE. Now, with this background, it might not come as a surprise that Dr. Barber is a passionate advocate for children with disabilities. So without further ado, please join me in welcoming our community discussant, Dr. Danielle Barber.
Hello, everyone. Thank you so much for inviting me to this wonderful forum. As you just heard from the introduction, I wear a few different hats related to this topic, but today I'm primarily wearing my mom hat. As we said, I'm a mom to 3 kids who are now 12 years old, 9 years old, and 6 years old. And today I'm mostly going to be talking about my oldest daughter, Noah, who is now in 6th grade. She was a preemie, and she also had HIE at birth. HIE stands for hypoxic ischemic encephalopathy, which is a mouthful. As a result of her HIE and prematurity in her NICU course, we were quickly immersed in a world of PTs, OTs, speech therapists, vision therapists, IFSPs, IEPs, a lot of acronyms, and a million doctor's appointments. I want to give you a little bit more about who Noah is now, so you have some context for the other comments that I'd like to share. As I mentioned, she's a 6th grader. She is bright and funny. She has an incredible sense of humor. She loves babies. She loves animals. She has a soul of a caregiver. She loves caring for other people. She also has moderate cerebral palsy. She has selective mutism, which makes evaluations at school really tricky because she has a lot of knowledge of things that she's not able to share with her teachers. And so it can be tricky for teachers to know how much she knows. She also has several learning disabilities. A sense of her developmental milestones. She started sitting independently at about 18 months old. She started, since we're focused on motor development in this session, she started walking with a gait trainer at about 3 years old. She first took her first real independent single steps at about 6 years old. And then at around 9 years old, she stopped using the walker consistently. And now she navigates the world mostly without a walker. She is working on getting up and down stairs now on her own. So that's kind of our trajectory in terms of motor development. One other thing is that I wanted to point out is that intellectual disability is not the same thing as learning disabilities. And this is a separate topic, but since they're all kind of interrelated in various ways, with various testing that we've had along the way through the school system and outside of the school system, we've had conversations about whether an intellectual disability diagnosis fits for her. And I have felt that we cannot do an accurate assessment of her intellectual abilities at this point because of all of the other parts that confound those tests. So I'm happy to answer questions about that and talk more about that if it's useful to someone. I love this forum because I think this is really the best way to learn how to navigate this world. We definitely learned more from a community, from our therapists and from other parents than from any doctor we had along the way. And I say that as a doctor. So a forum like this is so critically important. When we can build a community and learn from each other how to help our children succeed, how to navigate systems, what supports might be available. You can imagine it can be really hard to pick a meal when you don't know what's on the menu. So this is a great opportunity to learn what the options are and some various ideas on how to support our children. Okay, a few things that I wanted to point out related to Dr. Wilson's talk. First is that it can actually be challenging to access a physical therapist or an occupational therapist. And this varies drastically by where you live. I live in Philadelphia, and I care for patients both in the Pennsylvania area and also frequently in New Jersey. And there's a huge variation. Often the kids in Pennsylvania have easier access to services in the birth to 3 range. It varies county by county. And in some counties, they can be really generous for young children, infants and toddlers with physical therapy. In New Jersey, it can be really difficult. And I have had more than one family move from New Jersey to Pennsylvania because of the support of availability. Then as kids get older and graduate from that birth to 3 group, the access to these supports can become even harder. Private therapies are usually limited by insurance to short courses and don't just go on indefinitely. And school supports are often just barely enough to scrape by because their goal is not to help your child with everything. Their goal is really just to make sure that they meet the bare minimum to be able to access their education. And I'll just give you an example. My own school district, where my children go to school, we are in a public school district. We intentionally picked this school district because it is very well resourced and generally provides generous IEPs and supports to the students in the district. And we knew we would need that for our daughter. In this school district that has 8,600 students across multiple high schools, middle schools, and elementary schools, there is only one physical therapist for the whole school district. So you can imagine that there are a lot of kids who could benefit from PT at school who are not getting it, right? And again, this is in a really well-resourced district. You can only imagine how hard it is in some less well-resourced districts. So I guess the summary of that little point is that getting the old-fashioned kind of direct physical therapy can be tricky to navigate for a lot of families and children. So especially the second point is that especially early in life, motor development is so related to all of the other developmental domains. Children who don't crawl or move independently, it changes how they process visual information. We learned from our PTs and speech therapists, and we watched in our daughter that each time she gained a motor milestone, she also seemed to have a burst of language. And development is not linear, it comes in these bursts. And for kids with motor impairments, everybody, clinicians, therapists, educators, and parents should be doing two things. One is doing the therapy, the practice, the stretching to help the impairment get better, and also providing accommodations so the motor impairment doesn't hold back the child's progress in other domains. So one example I can think of this for our daughter, at University of Delaware, there's a program called Go Baby Go, where they have a person who develops these like toy cars, like the toddler driving cars, with a really big, easy button switch. So before Noah could crawl, she could sit in this car, push this really big button, and drive this little car around the house or around the neighborhood. And you could watch the gears turning in her head as she realized, oh, this means now I see something I want over there and I can go get it, which was really clearly a new realization for her. And last point that I wanted to make was that we can access some of the same benefits of therapy and get even more other benefits with other activities, like the kinds of things that Dr. Wilson was describing. Things like dance class, swimming, horseback riding, adaptive sports, adaptive skiing. All of those things are really useful. Noah has a better school day when we walk to school in the morning. She does better in math class when she gets, a brisk 10-minute walk in the morning. And for us, all of those things are really good for her motor skills, improving her balance, learning how to respond to falls. But it's also useful from the perspective of the F words. If you guys are familiar with the 6 F words of childhood disability, this comes from Peter Rosenbaum: functioning, family, fitness, fun, friends, and future. These are, it's a useful framework to think about what's really important for wellness and quality of life for kids with disabilities. So a couple of different, one last example is that she's participated in 2 programs now that are camps. It's an OT camp, but it's set up like a fun environment where she feels like she's playing games with other kids who have similar challenges and similar experiences. And the benefit is not just in the OT hand function progress. There is a huge benefit in terms of the social relationships and the dynamics and the fun that she's having when she's doing it. So just a few thoughts to share, and happy to go into the discussion.
Okay, well, thank you so much to Dr. Barber for those really interesting thoughts and observations. I love your analogy, Danielle, about how you can, how can you pick a meal if you don't know what's on the menu? And I thank you for your appreciation of these community discussions to identify what's on the menu. And we thank you for being a part of the conversation. We also welcome back Dr. Wilson, and we are going to open it up to our Q&A. So if you have questions for Dr. Wilson or Dr. Barber, please submit your questions on the Q&A toolbar of Zoom. To start off, our first question is for Dr. Wilson, but I think it would be interesting to hear from Dr. Barber as well on this question. How can parents support motor movement while they wait for therapy?
Yeah, I think that's a really great question and touches, and I'm definitely going to let Dr. Barber chime in on this as well. And I'll just quickly say, Dr. Barber, thank you for that excellent sort of description, all the points that you raised. I'm so glad you raised the F words. We've talked about that before, and I think that's really important factors we don't think about. So thank you for sharing those. So I think one nice thing about motor, one of the reasons we think about this is there's lots of ways to support motor skills. And I want to be mindful of not necessarily what's the word saying, I mean, physical therapy, occupational therapy, these evidence-based therapies are very important for kids. But when you deal with these accessibility issues like Dr. Barber mentioned, or these delays we see in the community, there are very readily accessible things that parents can kind of pull out of their, hopefully toolbox to help. So I want to allude even back to Dr. Lord's talk this morning in the Gilberts, where they mentioned drumming at home, finding toys that require you to do fine motor skills, the pushing, the pulling, the squeezing of things, right? This is what I alluded to in terms of family trying to really recommend less sedentary activity. And I get it personally and professionally. There's a lot going on. There's a lot of therapies. But as I say, what I'm talking about is a 10-minute walk, a walk down to the end of the block and back, like Dr. Barber mentioned, maybe if time allows, a walk to school. These are very little things that are actually very important for gross motor development, for coordination, for balance, and for physical and mental health well-being. And then it kind of goes back to some of the things that we were talking about at the end of the talk and Dr. Barber mentioned, which are these adaptive physical activity programs. And I think, I didn't present it today out of all the things I wanted to present to you folks, but we had a chance to do this Spark webinar and I did this sort of national survey where we asked everybody who was a part of it. And they talked about the fact that there's actually a lot of programs that are out there. It's about knowing which ones might be best for their child or adaptive for their child. So you can ask the program those questions. Have the coaches been trained? Do they have experience working with individuals with autistic individuals or those with ADHD or intellectual disability? What kind of experience? What kind of modifications do you make to the movements? Those are all important things. You can go to those programs and ask them. And what I'll leave with, so at a time for other questions is, one thing that I actually tell the coaches, but I also relay to families, even with the dance program, is this dance program is not looking for your child to become a world stage ballerina or dancer, right? Because understandably, again, both personally and professionally, I realize as a parent and as a professional, there's a lot of reservation saying, what if my child can't do that? What if they feel like they haven't met the expectation? The reality is exposure. So in the same way, how can you know what to choose if you haven't seen the menu? How can we expect some of these kids to have some of these motor abilities when they've never been exposed to these programs because we've focused a lot on other therapies? So just thinking about what's available in your community and bringing that back to your practitioner to even vet can be helpful. Dr. Barber, sorry, I spoke a lot there.
That was fantastic. And I echo all of those things. And I'll just add two tiny things. One example of, when Noah was little, she really loved ballet. She loved watching ballet. I think she was fascinated by how these ballerinas could do these incredible things. And so we started ballet classes, and we started in a regular ballet studio where the teacher was lovely. And she did it for about a year. But as she was getting older, she clearly felt like she was not keeping up with the other students in the class, and she wanted to stop. And so there's a role for integrating and being part of, least restrictive environment in school and engaging with typical peers in some settings. And there's also a role for feeling like you're doing awesome in an environment where you're at the same level as everyone around you. And I would not want to go have a conversation about the stock market in a room full of economists because I don't know anything about it, right? But, I'd be willing to have a conversation with someone who I feel like is on the same level with me in that domain. And then it becomes fun, right? And then you can really get a lot more out of it when you don't feel inhibited by how good is my performance. So that's one piece. The other piece that I would bring up is while you're waiting for therapy, don't forget the connection between sensory and motor. That sensory development really drives motor development. So I take care of a lot of babies, and parents of newborn babies, worry so much about what the long-term motor outcomes can be. The things that you can start really early include just holding your baby, dancing with your baby, touch, massage. Those things are really critical and really will improve motor outcomes too.
Yeah, thank you both for those important insights. And, there are quite a few questions that relate to this for Dr. Barber. And you mentioned ballet for Noah. And so one of the questions is, have you had experience with accessing community-based organized, physical activities? I guess ballet would be one. And, how did you seek these out? And were there benefits that you saw in those recreational physical activities that were different than other traditional therapies?
Absolutely. So I think the social piece is critical, really critical. And it takes some trial and error. Not every kid, just every kid, has their preferences of what their parents are pushing them to do versus what they innately love because it fits with what their personality. We tried varying things. We found a soccer program that had a specific team that was an adaptive program that was all about fun. It was a wonderful environment, but she was not into soccer. That was not her thing. So that's okay. She loves horseback riding. And so she had a great experience there. And then she gets the social dynamics in that environment as well. So swimming has been another great one for us. And I think that the social benefits are really critical. I can't say enough about connecting with local parents, because the best way you can find something that is reasonable for you to commute to and to commit to is connecting with local parents. And it doesn't have to be like based on a diagnosis, right? In my neighborhood, I don't love Facebook for everything, but Facebook is great we have a Facebook group called Mainline Special Needs Families, and families with all sorts of diagnoses are there, post questions, help each other out, say, hey, there's this great program over here, or this place is really good. And I think that's the best way to find opportunities like that.
Absolutely. I'm wondering if Dr. Wilson also has some suggestions in this vein about how families can access these recreational physical activities and what you recommend.
Yeah, I mean, I think, I very much like Dr. Barber said, that sort of connection with other families that have engaged in these, because therapies change, programs change, providers change, as many of us know. So having that family who's had that experience, again, not same diagnosis, but again, in that realm of adapted in a way, accepting, able for a child or an adult or adolescent to participate. I think there's other resources also. I will mention the Tarjan Center, for example. We have resources. We list resources. There is a part of this. My own research website lists some of these resources to go to. And then, I understand it's a navigation with the Early Childhood Intervention Regional Center. It's called here in California. But they do actually often, and I've been surprised actually at the level of resources they have that are organized physical activity programs or centers that actually provide those also. The Special Olympics website does also have some very nice sort of at-home skills and tools that you can do. This became particularly relevant during COVID, where they had a lot of home-based things that you could do. So if it's harder to make it, movements you can do at home. So yes, options out there, a little bit of searching. And I always said, if you have a good provider or even an ABA therapist, taking it back to them and say, hey, I found this, I read about this. What do you think? These people have experience in these realms too.
Well, wonderful. I just want to thank you both so much for taking the time to share, your insights, your reflections, all these great suggestions. The the Q&A is glowing with all of the wonderful compliments to both of you for your important work and your thoughts. So thank you. And we are now going to toss things over to Dr. Jasper Estebillo, our Director of Training, and she's going to share with us what's up next. Thank you.
Thank you so much, Drs. Wilson, Barber, and Lageson, for such a helpful discussion. I know that this is certainly a topic that a lot of parents that I work with ask about and are so interested in. And so I love all of these suggestions for integrating, working on these kinds of skills in the natural setting, right, with the family and in the home. I think that's a recurring theme for today.